Good morning, everyone. I'm Dr. Uday Kiran, dealing GIT with you guys. So, today, due to technical difficulties, I am unable to upload the PPT. Just a minute. I want to maximize it. Yeah, guys, today, due to technical difficulties, I'm unable to upload the PPT to you guys. So, I'll be speaking from my PPT from my tablet, so you guys can follow it. Okay. So today I'm talking about Helicobacter pylori infection. Um As we all know, that gastric peptic ulcer disease is a very important problem. Gastric and duodenal ulcer, acid, we call it acid peptic disease, and H. pylori causes most of them in developing countries, whereas in developed countries, that peptic ulcer disease may be due to your NSAID. So, as H. pylori is an important cause of gastritis, peptic ulcer disease, and many other conditions that we're going to discuss now. Now we'll be talking about H. pylori infection. Okay, so we have finished about liver discussion of liver in the last few classes. Now we are moving away from liver to stomach and small intestine. So H. pylori is the most common bacterial infection in the world. Taking into account every disease, H. pylori is the most common infection in the world. Like it's the key constituent of human microbe, gut microbiome. Okay, so the speciality about H. pylori is it can survive in the extreme gastric acid environment where other bacteria fail to grow. So this is a very common infection, especially in developing countries like India. The prevalence of H. pylori infection is from up to 80 to 90%. So most of us will be carrying this H. pylori infection within our gut. Okay. So about the bacterium, it's a gram-negative bacteria. It's a small comma-shaped bacterium with tough flagella on only one side, unipolar flagellae. It will be moving by that rotatory motion, spiral-like motion. The characteristic is it produces urease. What is urease? So we all contain urea within our blood and interstitium, right? This bacterium can break the urea. What is urea? NH2 CO and CO2 twice. Two carbon monoxide molecules bound to ammonium. Like okay, so whenever they break it, carbon dioxide and ammonium ion get released by urease. If you break urea, you get carbon dioxide and ammonium ion. Ammonia binds to H plus and becomes ammonium ion. So this helps in neutralizing the acidic environment in that locality. Ammonia, that NH3 molecule ammonia binds to H plus ion to form NH4 plus. Okay. So as it is binding to the H plus ion, it is taking away the acid. So it helps in neutralizing the acid in its environment. It helps this bacterium survive in the extreme gastric acid environment. Okay, so next is about the epidemiology. In the world, the infection rate is around 50%, whereas in India, it is around 70 to 80%. That it's more common in the low socioeconomic status. Usually, we are infected through the it's a waterborne disease for us, whereas in the foreign countries, like within a household, it is through fecal-oral transmission. Here, it is through contaminated water in India. So person to person is to gastro-oral, fecal-oral, oral route. Sometimes it can be iatrogenic when you put infected endoscopes. The patient get infected, and in the opposite direction, the patient can also transmit his infection to the doctor. Like most of the gastroenterologists get infected that way. So pathogenesis, coming to, like we have seen that the bacteria has can grow in the acidic environment. It is urease positive. It is highly motile organism. This is about the bacterium. So now what does it do to the body? So whenever it infects a human body, it goes into the gastric mucosa and attaches to the epithelium. It has a specific receptors for it, for specific for H. pylori, so that they can bind to that intestinal gastric epithelium. And as soon as they bind to epithelium, many factors, many things happen. One is because of the binding of an organism, inflammatory reaction takes place. Second thing, because of the urease, the local environment, acidic environment, will be transformed into basic environment, and bacterium survives there. And because of this, the a change in the local milieu, that acidic milieu, gastric mucosa starts secreting more acid. That also will happen because the feedback is gone, because now it is not acidic. The stomach thinks that okay, now I should be producing more acid because it is not acidic in the stomach, so it will be start producing more acid now. And the next thing is, it produces some vacuolating factors, CAG-A and VAC-A. These are the genetic islands in the DNA of the H. pylori. So these producing this CAG-A vacuum toxin will be vacuolating toxin, and CAG-A, I don't remember exactly what it's called, but we call CAG-A toxin. This will damage the mucosa. So there will be inflammatory reaction. There is a direct toxic effect. There is the local acidic milieu difference also. All these lead to inflammation of the stomach. Okay, so what does that do? It has several manifestations of, but what happens? One is inflammation of the stomach, that is called gastritis. The mucosa of the stomach will be inflamed. And the next thing is uh, acid peptic disease. So there will be, you can have a gastric ulcer, and you can also have a duodenal ulcer. So, sir, this is infecting gastric mucosa, but what? How does it infect duodenal mucosa? Because the mucosa differs from gastric stomach to the duodenum, right? So, what happens whenever there is increased acid production? The duodenal mucosa will undergo metaplasia and transforms into gastric mucosa. So, this H. pylori can live and survive in that gastric mucosa, and will cause a duodenal ulcer there when there is a gastric metaplasia. So that is how it causes gastric duodenal ulcer. And how it causes, like, going into the details, I'll be explaining to you. Like, then it can cause gastric cancer, and cause one of the most important things, gastric maltoma. Maltoma is a kind of lymphoma. Chronic inflammatory stimulation will cause malt. Malt is mucosal associated lymphoid tissue. The lymphoid follicles within the stomach, they get chronically stimulated, and you can get a lymphoma there. So, and one the most other important thing is gastric atrophy. So, how does this cause all of these infections? So, whenever there is H. pylori infection, there, as I said, there can be generalized inflammation because of any infection, right? That way, it causes gastritis. So there is an inflammation, the chronic gastritis. How does it present to the doctor? The patient can have dyspeptic symptoms. He'll be telling he's having bloating, unable to digest, unable to eat. His stomach is feeling always full. These kind of symptoms the patient will be telling. The next important thing is pan gastritis. This gastritis continues for long. You'll call it pan gastritis and gastric atrophy, because of the chronic inflammation that is happening. The inflammatory mediators will keep damaging the mucosa, and the mucosa eventually gets atrophied. That is called atrophic gastritis. This atrophic gastritis will cause a decrease in acid production because the mucosa is totally damaged. And second thing, because of the chronic ongoing inflammation, you can have gastric cancer in this atrophic gastritis. Any inflammatory cause, like, see, if there is chronic hepatitis, you can have a cirrhosis, right? Like, if you have chronic gastritis, you can also have a gastric cancer. In these patients, in pan gastritis, where the fundus of the stomach, body of the stomach, everything is involved, there is a decreased acid production in these patients. And when the next thing is antral gastritis, we have discussed about pan gastritis. Now, if only the antrum is involved, what happens? So if just the antrum is involved and not the body and fundus, in this antrum, your gastrin is produced. What is gastrin? It is a paracrine and autocrine hormone that is released from gastrin producing cells, that causes acid production from the body. From this antrum, gastrin is produced, and it helps in producing, and it stimulates production of acid from the body. So now what happened? This H. pylori is residing in the antrum. In the antrum, it is producing urease, and this urease has caused increased alkalinity within the antrum. So now what happens? Because there is alkaline medium in this stomach, more gastrin is produced because it wants more acid. It's a feedback loop, right? When there is more acid, gastrin gets suppressed. When there is less acid, gastrin production is increased. Now there is alkaline medium around the mucosa, gastrin production is increased. So this gastrin increases the production of acid from the body and the fundus, where gastritis is not there because only the antrum is present. Because that there is no inflammation, there is no mucosal atrophy in the stomach, in the body. Now more acid is secreted because of the increased gastrin production. So now hyperchlorohydria happens. Previously, what happened in pan-gastritis? When the entire gastric mucosa was involved, there was atrophy of the stomach and there is decreased acid production. That is pan-gastritis. That is predominant antral gastritis. In that, there is increased acid production. Now, what does this acid do? Stomach can defend from acid, right? Stomach can defend itself from acid because of the inherent defense mechanisms. Whereas this acid, when it goes to the duodenum, because of the increased acid in the duodenum, and now the duodenal metaplasia takes place. Duodenal mucosa is converted to gastric mucosa because of the presence of increased acid. And now this H. pylori can migrate to that duodenal mucosa because there is gastric mucosa there, and it will also grow there. So now from these two things, what did you understand? From in the antral predominant gastritis, there is increased acid production. In the body predominant pan gastritis, there is decreased acid production. So now what happens in both? In pan gastritis, because the fundus and the body is inflamed and damaged, you can have a gastric ulcer there. So in pan gastritis, you can have a gastric ulcer. Whereas in antral predominant gastritis, you will have a duodenal ulcer because of the increased acid in antral gastritis. You will have a gastric metaplasia in the duodenum, and H. pylori will colonize the duodenal mucosa, which has transformed into gastric mucosa, and will cause an ulcer there. So now you have clearly two mechanisms. One is pan-gastritis, which can cause gastric ulcer, and the antral predominant gastritis, which can cause a duodenal ulcer. Now what I am trying to say here is, in antral predominant gastritis, you will have predominantly duodenal. You can also have gastric, but you will have predominantly duodenal ulcer. Whereas in pan-gastritis, you can have predominantly gastric ulcer. The next thing is, because of the chronic inflammation that is ongoing, you can have gastric cancer, especially the pan-gastritis variety. When the whole gastric mucosa is involved because of inflammation, you can have gastric cancer. And the second thing, even when there is no pan-gastritis involved, because of the chronic bacterial colonization of the stomach, you will have chronic inflammation, lymphoid follicle stimulation, and you can have a maltoma, that is mucosal associated lymphoid tissue. That maltoma, we call it, that is a kind of lymphoma of the lymphoma presenting as lymphoid follicles within the mucosa of the gut. So how is it important here? Because this maltoma, though it is a malignancy, if you treat the H. pylori with infections, this can subside. This is one of the rare conditions where treating an infection will cause the regression of your malignancy. So I have covered like what all it does, like in the pathogenesis and the clinical like pathology. There are 5 different manifestations, like I said: acute gastritis, pan-gastritis causing gastric atrophy, antral predominant gastritis that may be causing duodenal ulceration, and pan-gastritis also causing gastric ulcer and gastric cancer and maltoma. These are the various manifestations. So there are other non-gastric association also. It may be a cause of immune thrombocytopenic purpura, iron deficiency anemia, Raynaud's phenomenon, scleroderma. There are other autoimmune, because of the chronic stimulation, your immune dysregulation may take place, and there can be other autoimmune manifestations like coming from migraine, Guillain-Barré syndrome, acne, everything. Maybe because of H. pylori. There is no direct evidence like linking these two, but you can try treating these patients with for H. pylori elimination if at all these other extra intestinal manifestations are significant. Okay, so in India almost 90% are infected. So if you test, you may find this infection in almost all the patients. But when do you test? Like, you test only when there is a clinical manifestation of it, or if there is increased risk of cancer in these patients or something, when it is clinically relevant, like somebody has peptic ulcer disease, somebody has gastritis, or there is family history of gastric cancer. In these patients, you treat the dyspepsia. What is dyspepsia? Feeling of fullness after eating a meal, unable to eat a full meal, bloating, chronic belching, all are these manifestations of dyspepsia. So whenever some patient has been complaining of dyspepsia also, you will think of H. pylori infection and you treat it. And otherwise, if the patient is not having any manifestations, you don't treat, because if you check for it, it will be there in almost 90% of patients. So So like I said, active peptic ulcer disease, history of peptic ulcer disease, and the patient has not been treated for H. pylori, gastric malt lymphoma, gastric cancer, and dyspepsia. In all these patients, you try for H. pylori testing. So how do you treat this patient? How do you establish the infection? So what are the diagnostic methods that are available for us to identify these patients? So you'll have endoscopic tests and non-endoscopic tests. So whether you do an endoscopy or not, how do you decide? So for example, somebody comes with a peptic ulcer disease, or you think there is a lymphoma in this patient, or you think there is a gastric cancer, you do an endoscopy. Otherwise, if you think there is just dyspepsia, you don't do an endoscopy in that patient. You use other methods to investigate this patient. So what are the tests that are available? Non-endoscopic tests, first I will be dealing. One is serological test. You check for IgG H. pylori. Because it's a chronic infection, chronic H. pylori infection, IgM will not be positive, IgG will be positive. You check for IgG infection, IgG presence in the blood. And the second thing you will be seeing is urease breath test. What this test is, I will be telling. The third is stool antigen test. These are non-invasive tests. So other endoscopic tests are you take a biopsy, you see for the histology. If H. pylori is present, it is positive. Other is rapid urease test on the biopsy material itself. You do an urease on the biopsy material, because it is urease positive, you will be able to identify. Third is culture. Culturing H. pylori is extremely difficult, but you still try to culture. Fourth is polymerase chain reaction, where you check for the DNA of the H. pylori in the mucosa, gastric mucosal biopsy tissue. So now I'll be telling about non-endoscopic tests. What are the tests that I told you? Serology, rapid urease breath test, and stool antigen test. Serology is you check for presence of IgG against H. pylori in the blood. So see, serology will be positive. Once IgG is positive, it will be positive for your life. But it is very sensitive. In every H. pylori patient, IgG will be positive. But the problem with this is, even after you cure it, even after you clear the infection, your IgG will be positive for your life. So this will be helpful in initially diagnosing, but not the follow-up of patient. So after you treat the patient, H. pylori is eliminated. To convert to establish that the infection has been eliminated, you cannot rely on IgG, because it will be positive for life. You cannot do anything later about it. So that is the most important thing. You can immediately diagnose the patient with serology without any invasive test, but you cannot follow up the patient with this test. The second thing is urease breath test. What is urease breath test? In this, you use radio-labeled carbon atom containing urea. As I said, urea contains CO, NH2, CO. That is the chemical combination. In this, the carbon atom you use 13C. Usually carbon is 12, right? Atomic weight. You use 13 carbon because it is mildly radioactive. You can detect it. So you use that urea and you make the patient consume it. Okay, you make the urea consuming liquid. The H. pylori within the intestine breaks down that urea, and now this CO is converted to CO2 because of the urease action. This radio-labeled carbon dioxide will be absorbed into the blood and you will be excreting within the breath. So whenever you measure amount of radio-labeled carbon dioxide within your breath. If that is more, then you establish that okay, now urease is present in his stomach, and that is causing the occurrence of radio-labeled carbon dioxide within his breath. So that is how you establish. You check after 5 to 10 minutes what is the amount of carbon dioxide the present patient is exhaling, radioactive carbon dioxide, and after 1 hour how much of it is he is excreting. If it is positive above a particular threshold, then you call it urease positive. What is the advantage of this test? Like before the treatment, you can establish the presence of infection. After the treatment, you can do a urease test to establish the elimination of infection also. If there is no H. pylori in the stomach, then you can say okay, this infection has been eliminated, because there will be no urease within the stomach. Because H. pylori is eliminated, your urease breath test will come negative, so you can establish the elimination of infection. What is the disadvantage of this test? This is a cumbersome test. You should take urea, radio-labeled urea, like wait for 1 hour and check the presence of radio-labeled carbon dioxide. It's a cumbersome procedure, requires some technical expertise, there is a small like dose of radiation that you can get, but that has not shown any significant cancer in anybody. So that is about it. That is about urease. Third is about stool antigen. You can check for the antigen in the stool of H. pylori. So you can use it both ways. It is readily available. It is sensitive. You can do it before treatment, establish the presence of H. pylori, and after treatment, you can again check for the antigen, and if it is negative, you can say that the infection has been eliminated. The next one is endoscopic test. Okay, like I said, when do you do endoscopy? This is all, like I said, all the three tests can be done before the presence of without an endoscopy. The three tests that I described above can be done even without an endoscopy. So usually they do this in the patient of dyspepsia. The other things, when you're suspecting a peptic ulcer disease, gastric cancer, or maltoma, you do an endoscopy, take a biopsy of it. On that biopsy tissue, you can do histological verification, like you can use special stains to see the presence of H. pylori, or you can culture it, you can do a PCR on it, or you can do a urease test on the tissue itself. So you can establish the presence of infection. And for follow-up, you need not do a endoscopy again. In some patients, like in presence of peptic ulcer, you do a repeat endoscopy, but otherwise you can do a non-invasive test for follow-up. So what is a disadvantage? It's an invasive procedure, may cause bleeding, may cause perforation, all this endoscopy. It's costly for the patient also. Usually you try to eliminate doing an endoscopy. So now, how do you treat this patient? See, this infection, whenever you think this infection is causing symptoms, you treat the patient. Otherwise, you don't treat. Okay. So you test for it when you are willing to treat the patient. That's about it. So the recommended regimens are triple regimen and quadruple regimen, sequential regimen. There are so many regimens. Usually you give treatment for 14 days with 2 antibiotics and 1 PPI. If you give 2 antibiotics and 1 proton pump inhibitor, if you take away the acidic medium, the bacteria cannot survive in it. So you use a PPI with it. It will also help in reduction of your gastritis. So next thing is about 2 antibiotics. What do you use? One is clarithromycin. The other one is amoxicillin. Many antibiotics are sensitive. Many are act against the H. pylori, but usually you use clarithromycin plus amoxicillin for 14 days with a PPI. On completion of 14 days, you do a repeat urease test or whatever test you are comfortable with, and establish the elimination of the diagnosis. But in some countries, the organism is resistant to clarithromycin. So in those patients, you can use metronidazole or levofloxacin along with amoxicillin, and that also you give for 14 days. This is, you call it triple therapy. So in some whenever the patient is resistant, like sensitive to penicillins like amoxicillin, then you use clarithromycin with metronidazole, or you use clarithromycin. You can choose your antibiotic dependent. If the penicillin is allergic to the patient, then you replace amoxicillin. If clarithromycin is resistant, you can use levofloxacin or metronidazole in its place. You can use this combination. In some countries, when the resistance is more, like you can use sequential therapy. 1 week you give 2 drugs, and another week you use another 2 drugs. So that is about antibiotics and PPIs. There is quadruple therapy, where you use bismuth subsalicylate along with the metronidazole and tetracycline 4 times a day. That's about it. Triple therapy, quadruple therapy. That's what you need to remember. PPI is a must. You use for 14 days. After the completion of therapy, you check for the presence of elimination of infection. In peptic ulcer disease, you also do an endoscopy to see if the ulcer has healed. Okay, that's about it, guys. I'm not going in detail about the resistance pattern of H. pylori, because it's beyond the scope of an undergraduate. Okay, thank you, guys. Well, after the completion of treatment, your maltoma will subside. If maltoma doesn't subside, you can go for chemotherapy for the patient, like, because it is a lymphoma. Gastric cancer, you can go for surgery along with chemotherapy. Peptic ulcer disease will get healed with the use of PPIs and antibiotics. Thank you, guys.